from the American Academy of Pediatrics.
An estimated 4.5 million children worldwide are victims of forced labor.
A new policy statement looks at human trafficking and exploitation of children and adolescents.
It's not about us. It's about the patient and about meeting them where they are. And if they're not in a place where they're ready to disclose or to talk about their trauma, we have to respect that. And that might make us uncomfortable. But disclosure is a process.
But first, it's July, and that means it's time for a new First Up.
I think we have to think about each patient's clinical picture, and we have to think about what's going on in the community with regards to viruses to come at a thoughtful approach.
These stories and more on Pediatrics On Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a research roundup from the journal Pediatrics.
David, I cannot even believe it's already July. What does that look like for you down there in North Carolina?
Oh, it's great. The deer flies finally stop biting and the mosquitoes start in earnest.
You know, it's funny, but in all these years, David, I have never asked you what your favorite season is, and I'm beginning to think it's not the summer.
No. You're wrong. Your instinct has been perfect because here's the thing. I don't really have a favorite season. I kind of enjoy them all. I have some least favorite insects for each season. And in the summer, it's the mosquitoes.
What's it in the winter?
In the winter, it's roaches, if they make it into the house. Or as we say here, water bugs. I don't know why. I don't want to talk about bugs, but I do want to ask our next guest what their favorite season is. We have on Dr. Rachel Moon, the Associate Editor of Digital Media for Pediatrics. Rachel, if you want to talk about bugs, we can, but what is your favorite season?
That's an interesting question because I think it kind of depends on where I am. So summer in the South is not pleasant, but summer in the Northeast is very pleasant. And I do have to say that I am a mosquito magnet, so I don't like to be where there are a lot of mosquitoes.
Well, we are totally agreed on that. But if you knew deer flies, you would welcome the mosquitoes.
I don't like deer flies either.
Yeah, they're the worst.
I don't like any bugs, and it's a fear of mine that I've now instilled in my children.
Oh, man. Well, sellers will teach them to like spiders if you want them to get over that fear. But we should probably talk about pediatrics. And as a hospitalist, I'm never sure how to handle a positive viral respiratory panel in a young febrile infant. Can I blame the fever on the virus? Or do I still need to be concerned about urinary tract infections and invasive bacterial infections?
So that is a really great question. It's actually kind of two questions, right? So for these young children, should we screen for respiratory viruses? And then if the virus screen is positive, then do we stop with the bacterial workup? So this month, we have a very interesting article that looks at the risk of bacterial infections in febrile infants, specifically in the age group of 61 to 90 days, who have respiratory viruses. And this article is by Dr. Paul Aronson from Yale and colleagues from the Pediatric Emergency Care Applied Research Network, or PCARN, which we're all familiar with. So they looked retrospectively at infants who are 61 to 90 days old who were seen in a pediatric emergency department between January 1st, 2012 and April 30th, 2024. And the infants had to have a documented temperature of at least 38 degrees centigrade. They had to have had received an evaluation for UTI and or invasive bacterial infection, and have had at least one respiratory viral test completed, either at the first ED visit or within 7 days. They found that of those who had urine testing, 8.7% were diagnosed with UTI. Of those who had blood cultures, 2.2 had invasive bacterial infection, and 56% of these also had UTI, and 0.2% had bacterial meningitis. Nearly half of the infants, 47%, had at least one positive respiratory viral test. And what happened if they had a positive test? So if they had a positive test, they were less likely than those with a negative respiratory virus test to have a UTI, so 4.4% versus 13%. They were less likely to have bacteremia, 1% versus 3%, and they were less likely to have overall invasive bacterial infection, 1% versus 3%. No infants with a positive respiratory virus test in this study were diagnosed with meningitis. And specifically, infants with positive tests for influenza, RSV, or COVID were all less likely to have UTIs, and those with positive tests for COVID were less likely to have bacteremia. So clinically, what does this mean? So should we be adding respiratory virus testing to our workups when you have a febrile infant? And can you hold off on the sepsis workup if the test is positive? We asked for commentary from doctors Catherine Hunt and Lise Nigrovic from Boston Children's Hospital. And they remind us that even though nearly half of the infants in this study had positive tests for respiratory viruses, first of all, viral testing can be expensive, especially if you test for multiple viruses. So you need to think about what viruses are currently circulating in your community and whether a positive viral test will change your management. So for instance, if the child is influenza positive, you might start oseltamivir. On the other hand, if you have a positive viral test, it doesn't necessarily mean that you have to stop looking for a bacterial reason for fever, because remember, in this group, nearly 5% of those who had positive virus tests, which is not an insignificant number, also had a concurrent UTI. So bottom line, I think we have to think about each patient's clinical picture, and we have to think about what's going on in the community with regards to viruses to come at a thoughtful approach.
Well, Rachel, speaking of viruses, one thing I do want to focus on is COVID-19. And with the FDA putting the status of next year's COVID vaccine boosters in doubt, what does that mean for pregnant mothers, for example, and their infants when they want their babies protected from COVID?
So this is a really great question. And I get questions about this all the time. Will the vaccine during pregnancy protect the baby? Is it better to get a booster vaccine dose during pregnancy, or is it better to get it after delivery and rely on antibody transmission through breastfeeding? I get these questions all the time because we particularly want infants to have these antibodies during those first 6 months of life before they can get the vaccine. So this month, Dr. Flor Munoz of Baylor College of Medicine and colleagues from the Mommy Vax study group, they look at these questions. So they enrolled a prospective cohort of infants between July 6, 2021 and January 31st, 2022. And they looked at infants that were born to 3 groups of mothers who were vaccinated with the mRNA vaccine, either Pfizer or Moderna, at 3 different time points. So 280 of the mothers got 2 doses of vaccine during pregnancy, at least 2 weeks prior to delivery. 202 got 3 doses of vaccine, either shortly before or during pregnancy, at least 2 weeks prior to delivery. And these mothers, they considered to have gotten booster doses. And then 32 got 2 doses of vaccine postpartum, with the last dose at least 2 weeks before the infant's 2-month visit. And the authors then measured antibody titers in the mothers at the time of delivery and in the babies at birth, 2 and 6 months of age. So of these 3 groups, the infants that had the highest antibody titers were those who were born to mothers who got the 3 doses during pregnancy. The second highest group was those whose mothers received 2 doses during pregnancy. And importantly, those whose mothers had 3 doses during pregnancy were likely to have antibody titers all the way out to 6 months, while those whose mothers had only 2 doses during pregnancy generally only had antibody titers at birth and 2 months. So the antibody titers were more long-lasting for those whose mothers had gotten the booster dose. When the mother got the booster dose was also important. If it was later during pregnancy, the infant titers were higher at birth, which then translated to a higher likelihood of having titers at 6 months. Babies were also more likely to have antibody titers at 6 months if their mother had had COVID infection during pregnancy or if they themselves had had infection during the first 6 months of life. whether the infant was breastfed or formula fed did not affect the baby's antibody titers. This study, I think, supports giving pregnant mothers the COVID-19 vaccine and giving a booster dose to those who have been previously vaccinated or who've had COVID infection, as this boost really optimizes those antibody titers in babies and protects them through 6 months of age. And it's better to vaccinate them during pregnancy than to vaccinate after pregnancy and depend on those antibodies from the breast milk.
Well, that sounds like some guidance that we can really use, especially coming into the winter. We spent the last couple of moments talking about newborns and babies in the first half of infancy. Let's look a little further into children with asthma. I've been a pediatrician for over 25 years now, and at some point, a while back, it seemed like everyone switched from treating acute asthma exacerbations with prednisone and prednisolone to using dexamethasone, either orally or injected. Do we know when that happened and why, and was it a good call?
So, as we have established several times, I am older than both of you. And so I think the last time I was on, I talked about how we used to treat asthma with 3 sub-Q doses of epi and then followed by theophylline. But since those olden days, we've learned that inflammation is a huge part of asthma. And if we don't treat the inflammation, then morbidity and mortality is higher for these children. So the initial studies, as you mentioned, were done with prednisone or prednisolone, 1 to 2 milligrams per kilogram per day for 3 to 5 days. And then that was standard treatment for many years. But then I think partly based on the studies done on children with croup, more doctors started using dexamethasone because since the half-life is much longer, you only have to give 1 or 2 doses. It does taste better, and there's less vomiting with dexamethasone. So you probably will have better medication adherence. So this month we have an article by Dr. Sriram Rangaval and Kenneth Mickelson from Lurie Children's Hospital in Chicago, who evaluate the use of dexamethasone for children being treated in the emergency department for asthma. So does it work as well as prednisone or prednisolone in preventing hospitalizations and return ED visits? So they conducted a retrospective cross-sectional study of nearly 500,000 ED encounters between 2010 and 2024 for children who were discharged from the ED with an acute asthma exacerbation and who got some steroid. Of these, 44% got either prednisolone or prednisone, and 56% got dexamethasone. So first of all, over the course of the study, there was this huge shift, as you mentioned, David, towards giving dexamethasone. So in 2010, more than 90% of the patients got prednisone or prednisolone. By 2024, 95% were getting dexamethasone. So secondly, this is kind of one of those good news, bad news things. The good news is that children who got dexamethasone were 10% less likely to be hospitalized within 7 days compared to those who got the prednisolone. But those who got dexamethasone were also 7% more likely to have a return ED visit within 7 days. So there are a couple of things about this study that I think you need to know about. One, they didn't actually tell us how much steroid the children got. So they could have gotten 1 or 2 doses of dexamethasone. They could have gotten anywhere from 3 to 5 days of prednisone or prednisolone. And then the authors mentioned that maybe the patients who got 2 doses of dexamethasone might have done better than those who only got 1, but they didn't really stratify the results by the number of doses, so we don't have that data to look at. I think we definitely need more studies that get more into the weeds of the duration and the dosage of the steroids, but it sounds like the two of them are fairly equivalent in reducing inflammation and asthma.
Well, Rachel, this is going to be great for anyone listening to change their practice this summer. And we don't get to see you again until the fall, so any fun summer plans you want to share with us?
We usually go to Vermont for a couple of weeks in the summer, and so we will be doing that this summer, and then just enjoying the new residents, I think.
Oh, so fun. Yes, it's true. It is July. A lot of new pediatricians.
Yes,
Oh,
a lot
boy.
of new pediatricians.
July the 1st. It is a special season indeed.
It is. We should have a name for the season.
What is it?
I don't know. We should have one.
Well, Rachel, in honor of the new July and your new house officers, we want to wish you happy Internpendence Day.
Oh my gosh. To all the new doctors listening, we wish you the best of luck this July.
It's going to be great.
It's going to be great.
In the meantime, to read the articles you heard about today, go to aap.org/podcast. Coming up, we'll discuss human trafficking and the exploitation of children and adolescents.
David, do you have any incidents from your clinical career that you just can't shake? I know I can think of some.
Oh, definitely. I think we all do. One that haunts me especially is a mother of a newborn who left the hospital shortly after the baby was born. And by the time we on the team recognized that she was almost certainly being trafficked, there was no finding her.
Ugh. You know, knowing the statistics, it seems likely that we've missed identifying a victim of trafficking in the past. I remember we talked about it in episode 147 with Dr. Jordan Greenbaum.
It's a great time to revisit this issue since the Academy just released a new policy statement on human trafficking and exploitation of children and adolescents. Today, we get to speak with one of the authors, Dr. Dana Kaplan.
Dr. Kaplan is the Director for Child Abuse and Neglect for the Department of Pediatrics at Staten Island University Hospital Northwell Health and Medical Director of the Staten Island Child Advocacy Center. She is also an Associate Professor of Pediatrics at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Dana, welcome to the show.
Thank you so much for having me.
To start off with just reading this policy statement, I want to orient our listeners to the terminology. Can we ask you to help explain, starting with children and adolescents experiencing trafficking in human beings and exploitation, or THB/E?
Sure. So I think in order to understand that very large statement, we have to sort of divide patients into subgroups. And we do that looking at federal definitions in the United States of how we describe human trafficking. So under the Trafficking Victims Protection Act, we divide trafficking victims into three populations. The first is children under 18 induced into commercial sex. The second is adults over the age of 18 induced into commercial sex through force, fraud, or coercion. And then the third are children and adults induced to perform labor or services through force, fraud, or coercion. So if we're just thinking about sex trafficking for a moment, the umbrella term in children is CSEC, the commercial sexual exploitation of children. After that, the difference is geography. Is this occurring within the boundaries of the country in which you're living, or is this occurring between countries? So in the United States, that would be referred to as domestic minor sex trafficking. It does not have to involve crossing state lines. It doesn't even have to involve leaving an apartment. It doesn't imply movement. So after that, then the subgroups of what we see many times are the same: transactional sex, pornography or child sexual abuse materials, escort services, internet-based, street-based, gang-based, exploiter-controlled, interfamilial, and survival sex are some of the subcategories that we see, especially in the United States. When it comes to labor trafficking, you notice that it's different than sex trafficking. In sex trafficking, the federal government recognizes that the very fact of being a minor means that you do not have to prove force, fraud, or coercion. You are vulnerable by definition. The difference with labor trafficking is you are able to work legally at certain ages, sometimes between the ages of 14 to 16, depending on the state that you live in. So that's why you do need to prove force, fraud, or coercion when it comes to labor trafficking in minors.
And knowing that issues like this are by definition underground, how do we get a sense of the scale of these problems? Do we know how many youths are involved?
That's one of the biggest challenges working with this population is we don't really know how many kids are affected. The data is really fragmented and we don't have clear definitions across different states or across different countries. So globally, what we can say is that the International Labor Organization estimates that over 3 million children are in forced labor. And within that category, about 2 million children are commercially sexually exploited. Here in the United States, we rely on information taken from hotlines and studies on runaway and homeless youth that, of course, are not super comprehensive, but we work with what we have. Some of those studies show that up to a quarter of these kids may have experienced sex trafficking. For labor trafficking, numbers range from anywhere from 5% to 50%, depending on the population studied. So it's happening more than we think, but we don't have a great way to capture it.
We know this is a global problem. Is the United States unique in how we deal with it?
We are. So it's unique in how it manifests, and it's also unique in how we've responded as the United States. So again, globally, trafficking might look like being forced into begging, domestic work, fishing, even armed conflict. But in the United States, it tends to show up more in agriculture, domestic work, restaurants, construction, and of course, overall sexual exploitation. One thing unique about the United States is that we have a federal definition of child sex trafficking and child labor trafficking. In the United States, under federal law, we do not have to prove force, fraud, or coercion. And in addition, we have child protective services, which is not something that necessarily exists outside the United States. And child protective services is a key player in the multidisciplinary approach to this problem. Now, in addition, while the federal definition does provide for children being viewed as victims, unfortunately, not all the states' laws have kept up with that. So there's at least about 23 states in the United States where children can still be prosecuted for, I say prostitution as a legal term. We don't use that term in the medical field, but they can still be prosecuted for prostitution. And we lack comprehensive safe harbor laws in those states to protect child victims of sex trafficking from being prosecuted.
And some states are currently moving to loosen their restrictions on child labor. Do you think that those legal changes might affect this situation?
Absolutely. I think that, again, as we already talked about, labor trafficking is really difficult to identify. And that's why we have such, difficult time getting statistics. So when it comes to child labor trafficking, I think when we start to change the laws around that, it might become even more challenging to recognize when a child is being exploited with the use of force, fraud, coercion. And that's when you have children who are being threatened to work. Otherwise, they're going to be harmed or their family's going to be harmed. And ultimately, these protections were put in place because children were being exploited, historically and engaging in illegal work or work that's harmful to their health, development, or education. So we want to make sure that, we protect kids when it comes to the work that they do.
And what do we know about the risk factors that might put young people at risk of labor or sexual exploitation?
So there are many risk factors, and a lot of that centers around when a system fails to protect a child or a caregiver fails to protect a child or there's dysfunction in the home. Many of the adverse child events relate to this population. So again, kids in foster care, kids experiencing homelessness, the LGBTQ plus population, youth with disabilities, they're at higher risk because they're more vulnerable. Poverty, family dysfunction, mental health issues, previous abuse, those are also major contributors. And there's the larger context. There's systemic racism, climate disasters, and immigration vulnerabilities that make children susceptible to this.
Speaking of those larger contexts, what about the internet and social media?
That's a great question. So, it's a double-edged sword, the internet, of course. I mean, it gives kids access to information. It connects them. During the pandemic, it kept kids connected, right? It allowed them to still socialize with one another to some degree. But traffickers do use social media to groom, recruit, and manipulate. And there's also sextortion, where someone pressures a child to share images of them and then use that for blackmail down the road. And it's not just images. We see live streamed abuse. We see all sorts of abuses of the internet when it comes to child sexual abuse materials. And digital safety education is incredibly important for not just kids, but also parents. And actually, the American Academy of Pediatrics is moving forward with a policy statement and a clinical report to address online exploitation. And I will be a part of that, very thankfully.
And knowing all of this, what should practicing pediatricians be aware of in terms of federal laws, like the ones you were talking about? And how can they help protect kids from these issues?
So I think that it's a really challenging landscape because every state is different. So in general, every state in the United States has laws that make sex trafficking a felony. Not for the person who's being trafficked, but for the person who is the trafficker. However, there are only about 23 states that have safe harbor laws, meaning that if someone is involved in trafficking, that's considered a criminal act. So we have a lot of work to do to make sure that we have all 50 states provide safe harbor law. And within safe harbor law, there's also variability in what protections the laws provide. So again, I think that's something that we need to all get on the same page with in terms of, the country as a whole. In addition, we do have mandated reporting requirements. And mandated reporting is generally when you see a child less than 18 who's abused or neglected by a parent or caregiver. So if there is a child coming in and you suspect that child is being exploited by a parent or caregiver, that provider should absolutely notify Child Protective Services. It's a difficult thing to do, calling in a report, but that's our obligation to the child to make sure that he or she or they are safe. So it's important to know your state and local laws, but really knowing your local resources to help with that process is paramount to providing trauma-informed care to this population, which is the most important thing when caring for vulnerable youth.
Are there systematic changes we should be making in our practices to help us better identify and support victims?
I think that we should, as clinicians, really shift again towards a mindset of providing trauma-informed care. And that's the recognition that most people, if not everybody, has experienced some form of trauma in their life. It does not have to be sexual abuse. It does not have to be sexual exploitation, but trauma happens to all human beings, parents and children alike. So approaching someone with that mindset allows them to kind of take the lead in what direction your evaluation goes and allows them to really be in control. And so this way, when we ask questions, we do it in a way that is supportive and less, trying to almost conduct our own investigation. So I think that really, I stay away from the term identification because that's really difficult. How do you truly identify someone who's being exploited? Well, it's when they self-disclose. And we know that self-disclosure is really difficult. We know that from the sexual abuse literature. People don't really disclose necessarily when the abuse is happening. They disclose later on. And so a lot of times when we as clinicians are worried about our patient, we want to know what's going on. We need to understand what's happening because we need to try and help. And I think what I've learned in working with this population is that we're not going to be able to rescue anyone. The best we can do is hear them and meet them where they are and provide medical care and let them know that this is a safe space where they can obtain medical care and no one's going to judge them. So asking open questions, asking, about their living circumstances, asking, you can't really talk about labor trafficking or sex trafficking if you don't talk about work and sex. So if you're going to talk about want to talk about labor trafficking, you're worried that something is amiss in this interaction, you want to ask, well, what do you do for money? How do you earn money? Or even to the parent, again, how do you earn money? What happens to that money? If you're worried about sexual exploitation, if you're talking to an adolescent, you have to talk to them about sex, what kind of sex they're having. If it's sex that they want to have, if it's sex that they don't want to have. And then you can start to ask more questions. If that person is not ready to talk about any of those things at all, and they're completely shut down, then we need to meet them where they are. And that is a really patient-centered harm reduction approach to this population. Rather than trying to keep leveling questions at them, really try and understand what their needs are and address why they're coming to see you. If they're coming to see you because they have a laceration, they hurt themselves, fix the laceration. If you have concerns, you can bring those concerns up, but know when to stop and know when to say, okay, I hope you come back and see me again. I think medical follow-up is really the most important part in caring for this population.
And what if pediatricians want to take their advocacy out of the exam room and really help with some of the policy that we were talking about, either in state laws or at the federal level?
Absolutely. I think that we see a lot of sensationalism out there, and I think we need to take it back down to the individual and really support children, adolescents, adults with dignity and how they want to be represented. So we are in a unique position to speak up. We need to advocate for safe harbor laws. We need to advocate for more resources, for more treatment programs, for trauma-focused CBT that's focused on those who have been exploited, complex PTSD treatment. Those are things that we should be advocating for on our local level, on our regional levels, and on a national level, as well as internationally.
Dr. Kaplan, this is such a weighty topic. It may be hard to come up with a single takeaway for our listeners, but if you can, what would you want everyone to know?
Get comfortable being uncomfortable is generally how I leave people. And I know that's really hard for us. We want to help. We're the helpers, right? And this is a population where you're going to be uncomfortable. It's not about us. It's about the patient and about meeting them where they are. And if they're not in a place where they're ready to disclose or to talk about their trauma, we have to respect that. And that might make us uncomfortable. But disclosure is a process. It's not an event. It happens over a long period of time. And we have to be able to find our support in dealing with those uncertainties. And that means creating a group around us where we can deal with our compassion fatigue, our secondary trauma, and working with individuals who may have experienced violence in their life.
Well, Dr. Dana Kaplan, thank you so much for supporting us in this talk today.
Thank you so much for having me again.
To read the policy statement, Human Trafficking and Exploitation of Children and Adolescents, go to aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, you know, it almost always comes back to the garden for me, but here's the thing. We have grown so many blackberries this year that we cannot possibly eat them all. Christy made an amazing blackberry cobbler, and even that did not knock them all out. So now we're going around to our neighbors with bowls of blackberries, and I love that because it gives us an excuse to visit with people and talk and really get to know the people around us in our community. And so this is sort of our blackberry diplomacy, if you will.
I wish they mailed well, David. So you could
I know,
send
they
some
would
up
be
to
so
Pennsylvania.
good.
My Say Ah is also something that I talk about a lot, which is my kids. We are spending the summer at a lake house in Connecticut where we generally go. It's my in-laws' house, and it's just a time of real togetherness where all the cousins are together. And so I'm really soaking in this family time because I think as they get older, they're not going to want to do this every summer. And so this might be the last one where we get all the cousins together, but I'm going to really try to enjoy it because of that.
Oh, you might be surprised, Joanna. We are headed to Ireland so that 5 cousins can enjoy one of their weddings together. And I think this goes on longer than we might be personally involved.
Oh, I really hope so, David.
Well, that's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. We're taking a summer break, but we'll be back in a few weeks to talk about the vaccine delivery system and how recent changes are affecting pediatricians.
We'll speak with the Chief Medical Officer for the National Nonprofit Association of Immunization Managers, Dr. Shelley Fiskus. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.